Welcome to this segment. We are going to be reviewing the lumbar compressive mobilization. This mobilization is great for the thoracic lumbar junction, the lumbar region, as well as the lumbosacral regions of the spine. We can do some compressive closing type techniques on the upside facet joints and mobilize the spine that way, or we could think of this as a gapping on the bottom side of the spine. So maybe I'm working on a facet or spasms or pain on the upside, and maybe I have a radiculopathy on the bottom side, and I'm trying to compress and get centralization with that. It works both ways. A great way to get and treat the patient, even stenotic patients, with this. Let's first talk about patient positioning. Patient's going to be positioned about 6 inches from the edge of the mat. I'm going to have you scoot forward just a little bit for me. Thank you very much. And about 6 inches here. I like to take their hand and have them either put it behind the pillow or behind their ear like this, so that they feel like they have some control as we kind of roll them forward, over some protection as they roll forward, and they don't feel like they're falling off of the bed itself. We're going to keep the spine relatively vertical in nature. We're going to go ahead and straighten this lower leg here, and then we're going to take the top and just hook the foot right behind the knee. We want to make sure that there's enough clearance that the knee doesn't press into the table at any time. We're not going to be putting pressure through that in this time, but sometimes we want patient comfort to be first and foremost. So as we look at table height, I'm just going to have my hands here, and my elbows are just going to be slightly extended. I'm not going to be at 90 degrees. That's going to be really difficult for me to get to the target from my sternum. So I want the patient just maybe about 15 to 20 degrees below 90 of table height. So a larger table or a larger patient, the patient will be a little lower. A smaller patient, the table might be a little bit higher. I can bias them into extension, I could bias them into flexion, or keep them in neutral based on what they need, or what my clinical reasoning is leading me to determine this would be beneficial for this patient. Patient or therapist positioning as your provider. My front foot, as I'm going through the TL junction, I'm going to have my feet offset so that my front foot is almost going straight towards the head of the plinth here, and my back foot is going to be in that same diagonal this way, and I want to rest my front leg kind of on the plinth itself. One of the keys to this is I need to get my sternum over my target. So we're going to roll the patient under us as we do this, but for me to be that close, this is going to be kind of a lot of body contact, and it's going to be straight down into there. I'm going to switch when I come down to the thoracic or the lumbosacral region so that I can get to my target over that. So it's really less work for me as the therapist. If I do this right, all I'm going to feel is this compressive forces through that, and it's going to not going to be a lot of shoulder activity or strength or anything like this. So like that. So even smaller therapists get a lot out of this with patients. So what I want to think about as we kind of look at our contacts here. So here is the spinous processes as we come down through here. So there's the spinous processes. We are not contacting the spinous processes. Our contact of our localizing hand, so this is going to be my localizing hand. I'm going to have a broad, and then I'm going to have a very specific contact. My broad contact is where I always start. It's going to be kind of the thenar eminence or thenar eminence of my hand. It is going to contact lateral to the paraspinals. I'm not trying to have a bony to bone contact. I'm not trying to get right into that joint. I want this to be kind of global, very, very comfortable for the patients. So that's going to be my localizing hand when it's a broad contact. When I go very specific, I'm going to do more of a pisiform, hypothenar contact. That's going to localize forces. However, that being said, when I am contacting with my broad contact, my mobilizing arm, that's going to assist in focusing and the localizing hand, is going to be kind of a contact like this. What the patient should feel is this very broad contact through the thoracic lumbar region, or through the lumbar region, or when we get down to the SIJ, you will have a large contact through here and through the gluteal musculature itself because of that broad contact. They shouldn't feel a specific spot of contact. When I go to my localizing technique, they should still feel a very broad contact, but they should feel as though the forces become more localized, even though the contact is very, very broad. That keeps it comfortable for the patient. So the other thing I want to talk about is our contact with our upper arm, with our mobilizing arm here. We're gonna put it right back here behind the apex of the ribs. Coming here on the apex of the ribs, very discomforting for the patient. So what I want to do is I want to think about this arm going vertical, and I'm actually going to grab with my forearm this area of the there's just this flat area on the rib cage itself that allows us, if you'll watch here, you can see that we get some top-down compressive forces by me just coming to that. But the key is that my arm is vertical. This is creating a compressive force down through my target as I go into that area. And then what I'll have is my localizing hand through here, and these are going to come down. So I can get this top-down rotation, and then I can get this bottom-up localizing force. When I'm working thoracic, lumbar, lumbar sacral, I like to take the top hand, bring it back so I have a little bit more control here, just have them relax. And then again, I'm going to bring that arm vertical. I'm going to come in, find my target segments, going to contact lateral to the paraspinals here, get a good skin contact in there. And then what's happening, you can see this hand is vertical, this hand comes vertical. And then the key is that I'm here, my back heel's off the ground. As I rock down, compress into the table, my heel kind of guides me on my depth of compression as I come down into the table with this technique. So this is the thoracolumbar technique as I come in there. If I feel like this is where the art of physical therapy comes in, maybe I feel like I have a better grip with this hand, I can make this my localizing hand, or if I want to make this the localizing hand for a pisiform, I can change with that too. So it's not one way, do it the way that's best for your body. But again, both my feet are faced that way so that I can drop down into the table. You rotate the whole body under you so that you can drop straight into the table. My sternum is right over my target. Again, I can use this as a very local and this as a very broad contact. And I can kind of go through here, let the patient feel that, always asking for feedback for localization of symptoms. And you can kind of change until you find something that is more specific, needs a little bit more work. And then I can change to a pisiform and really localize. But she should feel a very large contact area right through here. So that's the thoracolumbar region. As I come into the lumbar region, same thing, probably going to keep the same stance. As I come in here, we're going to, again, we need that contact on the lateral aspect of the paraspinals. I'm going to come in, again, nice vertical contact as I roll the patient under me. My heel guides how far I go into the table, and that is my broad contact. I can use the same hand and go to a specific contact. Or if I choose, based on morphology and the patient in front of me, I could choose to do a specific this way, or even a broad contact that way. Now as we come down into the lumbar sacral region, as we come in, here's her PSIS right in here. Come up above that, drop down. Here's my L5, S1. If I want to come into the lumbar sacral, I'm actually going to change my feet. Now my feet are facing towards the bottom of the table so that I can drop straight down. If I'm straight forward, my knees go right into the table and I have nowhere to go into the table as I'm doing this. So again, we come in, we're going to get our contact on the lateral aspect. So your thumb might be right over PSIS. You're going to bring this in as you're mobilizing as we kind of come down into the SI region. Again, sternum's right over my target. Drop my heel. That gives me my distance, kind of guides me as I rhythmically see if we can get some loosening, centralization, decrease in spasms, decrease in pain. And then if I want to get really specific, I can come in right into that area this way. Both of those should be very comfortable. Patient should feel contact all the way through this region. but should feel a localization right in that area as we come in. The biggest mistakes I see is that a lot of people put their elbow here, very discomforting for the patient. The other thing I see them doing as they're coming down is they try to do this osteopathic rotation. This is not a rotatory mobilization, but a compressive mobilization. Closing the top side, bringing it into extension, as well as gapping the bottom side. So I hope that was helpful for you. If you have any questions, type them into the chat box below. We love to get back to people, bring clarity, certainty, and confidence to your manual therapy skills and techniques.